So CME code, and it will be towards the end as well. Okay. So as a neuro-oncologist, I treat all kinds of brain tumors: primary brain tumors, gliomas, meningiomas, brain metastases. Those are secondary brain tumors, pediatric brain tumors. So basically, the pediatric brain tumors would be seen in patients in 19, 20-year-old young adults. So I am able to see anybody 19 years old and older, seizure management for all of these tumors as well. Today's agenda, of course, we talk about the landmark study from 2024 since the IDH inhibitors got approved, and we have been using it a lot on our patients. That's the vorasidenib. That after that, we talk about the targeted drug treatment in gliomas. A lot of things that we use as targeted drug treatment would be basically what I call it as personalized medicine. Hereditary disorders, so NF1, NF2, chromatosis, VHL, what all drugs are we using then? So it's not only about radiation and TMZ anymore. Brain metastasis is a really vast topic. I won't be able to cover everything, but I mean, we just had a clinical trial, gamma tau, we can talk about that. Future directions, what all is exciting coming up, and of course, what all trials are open in neuro-oncology here at Louisville. Okay, so this pretty much standard slide, and I'm sure the residents are bored of this by this time, is that still addition of chemotherapy to the radiation is shown to be the best treatment for these tumors. So high-grade gliomas, extent of resection as early as 2011, we know was established. So maximum safe resection helps with overall survival. Other than that, radiation with TMZ or radiation with PCB, which is basically flucarbazine, CCL lomustine along with vincristine, it helps in overall survival for these tumors. So if it is an oligodendroglioma, usually grade 3, we would treat with PCB. If it is astro, then according to the Catnan study, adjuvant had the adjuvant of 12 months in grade 3 astrocytomas had the longest overall survival. So that's practice changing now. So for grade 3s, that's how we treat. And of course, the grade 4 astrocytomas, GBMs, we radiate with TMZ and also give adjuvant. And you might have seen patients wearing something like that on the upper hand corner. That's called Optune. It's a tumor treating fields. They're low dose electric alternating fields that help interrupt the mitosis in tumors. And that is also an FDA approved. So we offer it to patients after radiation. It's FDA approved for GBMs actually, but I mean, some astro grade 4s want to do it as pretty much less treatment options. So they also opt for this treatment. Adds to a couple of months for overall survival. So, I mean, just an overview of treatment here for IDH mutant tumors. We know that GBMs are IDH negative tumors, and the IDH mutant tumors are astrocytomas and oligodendrogliomas, pretty much just two. But there are three grades: grade 2, grade 3, and grade 4. So when we talk about grade 4, it is only astrocytoma that's grade 4. Oligodendrogliomas are grade 2 and 3. So grade 4 astrocytoma is pretty much treated like GBM. So we give radiation with TMZ, the concurrent temozolomide, and also add adjuvant temozolomide to it. When we talk about the grade 3s, we know that the grade 3 I just mentioned, according to the Catnan study, add adjuvant TMZ, you can treat grade 3 oligos with PCV. So more data is coming from the Bola French study to even use PCV in grade 3 astros, having a better overall survival. But what about the grade 2s? What was the practice for treating grade 2? Grade 2 gliomas are low grade. They're slowly growing, but I mean, they are still tumors, aggressive. They are still gliomas, right? They are not like grade 1, like pilocytics and others. So how to treat these? So we call them Pugliese factors, but if the patient's age was 40 years, let's see if I can show you. If the patient's age was 40 years, subtotal resection, hemiparetic, and poor performance status, those patients basically, we were not following with observation. We would treat it, just treat it like radiation, give chemo. They did overall good. We know that the grade 2 gliomas, if you treat them with radiation and you treat them with chemotherapy, the overall survival would be good. But they are getting radiation. And these are the younger patients who are 20, 30-year-old getting radiation at that age. So remember all the side effects he's going to get from radiation. But then we had the other like low risk patients, lesser age group, completely resected tumor or a little bit left behind, we never gave them radiation. We knew these are great because they're going to slowly grow. So we used to observe these patients, and this is where we are targeting the new vorasidenib. So again, we know overall, just I mentioned, the overall survival is good with radiation chemotherapy, but we don't want to give radiation to younger patients. We don't want them to have a lot of side effects as things go by. Radiation can cause a lot of problems for, I mean, they have longer life to live if they are getting radiation at 20-year-old. So this is the landmark study targeting those patients where we were observing them and not giving radiation. So this is the Indigo trial. It led to the FDA approval for vorasidenib, which is an IDH1 and IDH2 mutant inhibitor in low-grade gliomas as of 2024. I have maybe up to 10 patients on this medication at this point. FDA approved, as I mentioned. So IDH, so never confuse GBNs with IDH mutant, especially for the residents. I would say IDH mutation is present in astrocytomas and oligos in grade 2, grade 3, and grade 4. So grade 4 is only astrocytomas. And if you look at the graph below for the age group, these are the younger patients, GBNs. So GBNs are the ones that are basically seen in the older patients. So younger patients, more of astros and oligos have this kind of mutation. At the molecular level, if you see up there, the IDH1 and 2 enzyme is needed to convert basically isocitrate to a substrate called alpha-ketoglutarate. That leads to further, if you see, KDM, TDT, those are the HIF1 alpha degradation is carried on by alpha-ketoglutarate. But if there is a mutation present in IDH, so instead on the right, if you see instead of IDH wild type, if the tumors are mutated, then actually the alpha ketoglutarate changes to a new substrate, D2HG. So D2 hydroxyglutarate, which is very, very epileptogenic. And see these tumors, that is how we also need to look into the clinical presentation. Whenever I see a patient, younger patient coming with seizures, most likely would have an IDH mutant tumor. So this is the collection of 2HC highly seeding these tumors. As you see in the next graph, these are the MRI, which are 2HG edited, whole brain MRIs. And here you see all that bright signal is the accumulation of 2HC in these tumors. So definitely we had already established production of this 2HC in the tumors and overall. So ivosidenib, just a quick mention, not to confuse everyone, ivosidenib is an IDH1 mutant inhibitor. And vorasidenib is both IDH1 and IDH2. And IDH2 is a non-canonical mutation seen. So we had been already using ivosidenib a long time ago. It was more about knowing enhancing or non-enhancing tumors. We knew ivosidenib was kind of effective in non-enhancing tumor. Now, non-enhancing tumor, we already know means low-grade gliomas. So this, again, the graph shows that how the rate of growth in the red out there is going down with the use of ivosidenib. So controlling the rate of growth of tumors, leading to shrinkage in few of them. Again, the same thing with the swimmers and the waterfall plots that we see, non-enhancing, if you see, is responding way better than enhancing tumors. Very few of them in the swimmers plot is responding to ivosidenib. Again, saying that IDH mutation dependent growth of the tumors is usually low grade and not in high grade. There are different mechanisms that come up when the tumors they convert to high grade and they do not depend on their IDH mutation to grow. So, and then there were other studies, a lot of peri-op studies that you see here, where ivosidenib, vorasidenib together, and were given like in different arms, peri-op, and also noticed to have what was the overall survival. Actually, what was noticed was how much was the accumulation of vorasidenib and ivosidenib in these patients' tumors when they were removed. So these studies are really helpful to see if one of these drugs would be more effective. And you clearly see the accumulation of vorasidenib being the maximum here in the tumors in terms of the levels of 2HC. So 2HG was lowest with vorasidenib, and that's why that drug was preferred. And maybe because of better, pharmacokinetics, and though, or maybe it was that all the patients don't have IDH1. Some of the patients have IDH2 mutation too. So kind of multifactorial, but definitely 2HG was lowered maximum with vorasidenib, And that's why that drug was chosen for this randomized clinical trial, which is a landmark trial in brain tumors. I mean, talking about brain tumors, we don't even have any substantial, advancement in GBM. So, I mean, this was a big deal. It's a pill that patients take, vorasidenib. And this trial was a placebo controlled, double blinded, randomized trial for the low grade gliomas. So, grade 2 gliomas, oligos, astros were included. They needed to have some amount of measurable disease so that they could know whether this could follow something, right? Rather than complete gross total resection. So, that was the criteria. Crossover was allowed. We're just gonna skip all the patient characteristics. It was like number of male, female, seizures. Of course, newer data is coming that it also helps with the seizure control. As I told you, too, Hg accumulation is very epileptogenic, and that's why seizure control is good with this kind of medication as newer and newer data is coming up over the years. Excellent PFS, excellent graph here. Vorasidenib with a median of 27.7, placebo only of 11.1 seen. And look at this, a flat line pretty much for time probability of being alive and next receiving the time to next receiving intervention, a flat line for vorasidenib. So patients who are on vorasidenib didn't even need radiation, didn't even need any TMZ, or didn't even need any surgery for up to like 30 months. And now newer data are coming up. They are still doing good and don't need any new intervention. So great landmark study. So before you start treating any grade 2s with radiation and chemo, please consider vorasidenib. It's a game changer. My patients on it, the only thing that I see is increased liver function test that sometimes leads to dose modification for a couple of them, but majority of them fly through it. Very easily tolerated medication. So this is a game changer for younger patients with IDH mutant gliomas if they are caught earlier in the stage, and of course with seizures, yes, this can be game changer for them. We don't have to radiate those tumors. So that was pretty much about the vorasidenib, and then we have a lot of other targeted drug treatments in gliomas. Basically, I'm going to talk about all those FDA approvals, what is new coming out for last 2 years. H3K27M, lethal tumor for children. So this one is almost 100% of the children don't make it if they have a midline glioma. The latest, we call it H3K27M on the basis of the mutation. It's a H3K27M midline glioma. The older name was DIPG, but I mean, it's not limited to the pons anymore, and we know what mutation it has. So that's the newer name. Guess what? We now have the only FDA approved medication available for this as of, I think it was as of August 2025. So just a couple of months before dordaviprone, which is ONC201, this medication got approved. The only first FDA, and it is very exciting news in the pediatric tumor world, especially with extremely lethal and unfortunate tumor. I'm gonna give my voice a little bit of rest if possible. Do you know how can I bring up the video? We can hear it, but not seen. Is that? I think it should work, but I mean, I can definitely hear that one. Oh, you're able to see it online?
You could see it online, the video, but
It's kind of strange. No.
Because is it open in a website?
Yeah, it just works in the presentation. Okay, then maybe we can just listen to it because I'm not able to look at it. Oh, it's working. It is working. Oh. So what do you mean? Yeah, it's gonna work. Hopefully. Okay. Sorry. Okay. Okay, so that's the mechanism of action of ONC201. It's a pill. Just to the next slide. Was the action trial. It was an international. It was. I'm impressed that it was a double-blinded, randomized, placebo-controlled trial. It was on 201. I think we had transferred a couple of patients to WashU for this trial. So newly diagnosed H3K27N, whether I mean usually pediatric, but they would take younger adults too. So this would be only if the patients had completed upfront radiation, and then they were randomized into three arms, either receiving placebo, which is I'm impressed what they were able to do in this trial. The second was dordaviprone once a week, because I mean this was interesting that how they did dose establishment in the same phase three trial. Twice weekly dordaviprone was a third arm, and you see the waterfall graph. It is you can see the tumor responding to it, and the spider graph down there too, with an overall response duration of 36%. And there was duration of response, for median duration of response in months would be around 11.2, and the time to response was around 8 months, which is pretty good for something which is extremely lethal, 100% lethal of this grave tumor. So a landmark study, it's available as a oral medication. So we have another tool in our pocket now. Talking about the other things that you can use in tumors. So other than radiation TMZ, we got something more. So BRAF inhibitor. So this is a basket trial, all comers, all kind of tumors, including brain tumors were included. Now BRAF V600E is targetable with dabrafenib, and we also give MEK inhibitor trametinib in these patients. Which all tumors have BRAF V600E mutation. These are our you can call it lower grade tumors. PXAs, I mean, they can be grade 3 also, but at that point, we definitely want to radiate them. PXAs, and then pilocytic is the fusion, that the BRAF fusion that we see. Gangliogliomas are the other ones, and GBM, yes, a subset of GBM are BRAF V600E positive, and I have actually patients on this treatment. So these all tumors were included, a high grade, low grade with all the BRAF. And then, I mean, they had a good response, overall survival for 17.6, PFS 3.8 months in the higher grade cohorts. In the lower grade cohorts, I mean, they did good. I have a patient with plenty that I presented in symposium. She's on this treatment, and there is no evidence of tumor. As long as she's taking this medication, there's no evidence of tumor. So again, targeted, or people call it personalized medicine, that we use in neuro-oncology work. The other is Firefly One trial. Again, really good work coming out of DC Children by Lindsay Kilburn. So tovorafenib. Again, I have a couple of, at least one patient on this medication. So we know that BRAF V600E is targeted with dabrafenib. But then there are other BRAF mutations. There is type 2 BRAF mutations, which would be not V600E, but they are targetable, which means that the tumor is dependent on that mutation for its growth. But then the grade 3 are the ones that are dead mutations, which means that tumors are not dependent on those. So targeting the second type of mutations, or basically this got approved for treatment for pediatric tumors that was resistant or recurrent to the original use of BRAF inhibitors. Then we use a type 2 RAF inhibitor. So basically, this is tovorafenib. Again, see a lot of rash, the usual side effects of these medications, rash and vision and other things. Yes, definitely seen in this one too. But again, this is available and it is approved after the Firefly study, which was again phase 2. Excellent waterfall graphs if you see how the tumor growth was reversed after using. So this is the Raynaud criteria. The rapino and all that is the pediatric Raynaud in the middle, but you see how the rate of growth of the tumors are changing with this medication. Again, already getting used in our world, mostly by pediatric, but I use it for my patients also. NTRK fusion, I think it would be more like medical oncologists knowing about it, but it is also got into, as you see down there in the NCCN guidelines for brain tumor. So larotrectinib and entrectinib. So if you find NTRK fusion, I feel like lucky to find NTRK fusion in any of the brain tumors, you can target it, especially when the tumor is recurrent or after radiation. So again, these were phase 1, phase 2, involved again any of the solid tumors, metastatic, any kind of the tumors who received entrectinib. And then again, similarly, you see the waterfall graph with a beautiful control of these tumors that was seen with this study. And it is FDA approved. If you find NTRK fusion, please go ahead and target it with this medication, adults as well as pediatric. And then similarly, larotrectinib. Now, I personally did not find any NTRK fusion that I'm looking for in my patients, but pediatric patients, again, larotrectinib is the other medication that we use, and some of the graphs showing how the spinal cord tumor had responded in a pediatric patient. Again, a beautiful waterfall graph with all kind of tumors, whether it is pediatric low grade, adult high grade, responding to the fusion. So basically targeted oncology. That is what we also should know in brain tumors, right? There is a lot of things that you can target in brain tumors. So pathology, NGS is everything. Everolimus, I just want to bring it out here. So, I mean, you might have heard of everolimus in meningiomas, some phase 2 trials with everolimus and senvastatin for meningiomas, kind of okayish growth control. But again, everolimus is actually used after the trial, which was again placebo-controlled phase 3 trial for tuber sclerosis patients. So these are the younger patients, or you can say children. I mean, I had a couple of children that I saw in UVA who were in, these are tuber sclerosis with SEGA, subependymal giant cell astrocytomas, that we treated with everolimus. Everolimus is actually pretty good, well tolerated by kids, and excellent response. No great growth of these tumors on everolimus. So just bringing it in again, pediatric. I don't think so. I have seen to need to treat the SEGAs in adults, but again, it can be if you. This is especially helpful for our neurology colleagues about hereditary disorders. So this is we have agents available for all these now. And F1 neurofibromatosis 1, you know all the stigmata, how to recognize these patients. I'm sure you are following some of them in your clinic. And F2 related schwannomatosis. Now, schwannomatosis is of three, actually, maybe four types. And F2 related schwannomatosis, those are the hearing loss, schwannomas, the vestibular nerve patients, SMART-B1, SDTR1, which I have at least two patients. And VHL I included here, not really, but I mean, we do have something to treat VHL now. Selumetinib. So we already knew that selumetinib, which is a MEK inhibitor, was approved for treatment of plexiform neurofibroma in children, basically. So this got approved because of a phase 2 trial earlier, I think a couple of years ago, was I'm thinking was 2020. It would have been the next slide. So 2020. So this got FDA approved for plexiform neurofibromas, right? Selumetinib was a big trial through NIH earlier, a couple of years ago. So other than that, you can also use selumetinib in your NF1 patients if they have low-grade glioma. So they do have a lot of pilocytic astrocytomas that sometimes, if your biopsy is good, if you're not, you can still go ahead and use this MEK inhibitor to control these low-grade gliomas in NF1 patients. If and then it is targeted. So if you have BRAF V600E or a fusion, as I already told you, the fusion in the pilocytic astrocytomas, you can go ahead and use selumetinib. So, so again, 2020 landmark study in inoperable plexiform neurofibromas. So plexiform neurofibromas, again, for our trainees here, are sheet-like neurofibromas that cause pressure problems, disfiguration in kids, or adults when they are present on visible surfaces. Not all of them can be operated. Like one in the neck has associated like major vessels around it. So for that, selumetinib in kids. Now the problem that I was facing as an adult oncologist is I have tried my best, but I could not get selumetinib approved for my adult patients until mirdametinib got FDA approved. So this was a trial, RENU trial, running for mirdametinib, which is another, you can just call it another MEK inhibitor. If you see the mechanism of action, it inhibits, so it's a MEK inhibitor, right? But this is the, probably everybody knows at this point, the RAS, MEK or cycle. So this one is targeting the MEK, and there are a couple of MEK inhibitors. Selumetinib, mirdametinib is the one that is now FDA approved for all kids and adults with NF1 plexes. So selumetinib, mirdametinib, you might have heard of trametinib, binimetinib in a melanoma world. This one got FDA approved, I'm thinking it was February of 2025, and I have patients on it already. So this was a RENU phase 2 trial, excellent response again I had through the trial, 2 patients at UVA that we received good response, and of course, I was just waiting for its FDA approval. So RENU phase 2 trial showed decrease in the rate of growth, shrinkage, as you see on the graph for all those plexiform neurofibromas in kids and adults. So we have options for our NF1 now. We have MEK inhibitors to treat not only the brain, like low-grade gliomas, but also the plexiform neurofibromas. Just remember that when you see your patients, if they need that treatment. So the other thing is NF2s. Do we have anything to offer for NF2s? Yes, we have. We had bevacizumab, which is Avastin. It's a VEGF inhibitor. It's an infusion. We had that available for our NF2s for quite some time. There had been a lot of studies coming from MGH by Scott Plotkin about and Jayshree from Hopkins. They both did a lot of studies on BEV for use for hearing preservation in these patients. Even if there is no rate of growth, if you don't see any growth of those vestibular schwannomas, you can still use this agent to preserve hearing. You can still have hearing loss with no growth of tumors. So BEV was already used, and I had patients on it until now. We have brigatinib through the phase 2 trial also studied, and it almost had identical kind of results with BAV. There was, if you look at the graph on the right, the spider and the waterfall, you see the growth of the tumors was controlled with this tumor. And it's not only the schwannomas, ependymomas and meningiomas, which are also seen in NF2, they responded as well. But if I have to use only for hearing preservation, I might use BEV, though almost 30% was the rate of hearing preservation in both of them. So we have something more for NF2 patients. I just wanted to bring in VHL. Probably already people know about it because this was almost 2020 or 2022. I'm blanking out for the FDA approval for belzutifan. It's a HIF inhibitor. So we know the hypoxia-induced factor. That's that's the mechanism of action of hypoxia-induced factor leading to all the tumor productions in VHL. VHL patient 1 Hippolyndau has a lot of tumors. The main ones that we see is the hemangioblastomas, and they could be multiple hemangioblastomas in the brain, spinal cord, and of course you see then renal tumors as well. So we are using this very, very easily tolerated medication. Excellent graphs, if you will. the percentage of change from the baseline for all these tumors, how they shrink. And I have my patients on it who are very stable, no problems at all, and have shown shrinkage, excellent shrinkage of these tumors. And I mean, of course, if there is a big cerebral or tumor sitting, hemangioblastoma sitting there with a lot of pressure or symptoms or something, then yeah, I mean, you need to operate on those. But if you have multiple of them, then I mean, this is a wonder drug for our BHL patients. Sorry, 2021. Here you go. August 2021 was it when Lazultiman was FDA approved. I guess everybody having VHL are on it now. Side effect wise, side effect profile is not bad. It's anemia and fatigue. You have to measure the oxygen saturation for these patients. If patient is anemic or SATs are low, you can go down on the dose to 50%, but around 80 is the sweet spot when they are able to tolerate and still have good effects. So in general, I mean, that was the spiel about targeted treatment for gliomas. Brain mets is a vast topic. What I can say is, I mean, brain mets, our neurosurgeons do surgery for symptomatic ones. We end up radiating them with SRS, whole brain, when needed. I mean, we can do whole brain, and also hippocampal sparing whole brain. Asymptomatic are the ones when I consider for targeted treatment. Lung cancer, EGFR, osimertinib, we can do alectinib or ALK, which has excellent response in brain tumors. We can use all MELD. Pembro we've been using melanoma, of course, always consider BRAF inhibition before radiating the melanoma brain mets. If you enroll, of course, if they're smaller, can be considered. Game changer. So there are so many new agents available, especially for the HER2, where the response is excellent with all these agents and HER2. And then HER2 climb is basically in HER2 along with other agents have been excellent response, even with leptomeningeal disease. Now, excellent means maybe for 2 years or so. Of course, they are not curable, but able to have evidence, no evidence of active disease in these patients. Just trying to, I don't think so this is open, but our neurosurgeons might be able to tell me better if this is already closed. But UWEL is the Center for Excellence for Gamma Tau. So we did a lot of surgeries for gamma tau. This is for brain mets. So if there's a brain tumor, you resect, and after the resection, place these gamma tau with the cesium-131 placement of radioactive taus in the tumor cavity. So this was the clinical trial that we had, at least for the brain mets. So they had 4 arms: newly diagnosed brain mets, recurrent brain mets, newly diagnosed GBM, and of course the other one is just a registry. So for brain mets, we placed these tiles as the patients were randomized to either getting SRS. So anybody who has a brain met removal from the tumor by surgery needs to have the tumor cavity treated with SRS. So either you're treated with SRS or you get randomized to treat it with gamma tau. So that was a clinical trial open, and a newer data is coming up that it has been showing to be having more PFS than the SRS, but very early stages still. So I guess wrapping up at this point, future directions. We talked about precision oncology. We already knew a lot about radiation. We know that chemotherapy, immunotherapy, yes. Lynch syndrome. I don't treat Lynch syndrome with TMZ. I treat Lynch syndrome with pembrolizumab. So make sure that the same. I mean, all tumors and treatment don't fit under the same umbrella. We need to be very careful, especially with the history taking. If the patient has a history of multiple tumors himself and had multiple tumors in the family, always consider a genetic disorder. And these patients, if you do the NGS, would be having higher tumor mutation burden. If they have high TMB, please consider immunotherapy. They have better survival than the regular patients who are not Lynch syndrome. So we unfortunately didn't have this trial, but Just very briefly about gamma delta T cells, there is a trial and some early results. I think it was presented in ASCO this year and also Neuro-Oncology Journal, very early results, phase 1, phase 2 trial of using gamma delta T cells. These are the type of T cells that do not need antigen presenting cells, and they can be used against the tumor for the patient. So basically, this trial was extracting the gamma delta T cells, and after the patient got radiation, when there was time to get the adjuvant treatment with TMZ, they also got the intratumoral injection of these gamma delta T cells, which would go ahead and kill the tumor. This is very early phase 1, phase 2 trial, mainly about the tolerating this. And also, they had changed the gamma delta, or we had changed the gamma delta T cells so that they become TMZ resistant, just because we were using it along with TMZ. So very early stages, come data coming out. TILs, extremely early stages. People are thinking about using TILs as an experimental stage, phase 1, phase 2 for maybe only due at this point for brain tumors. And the company here was in 8Bio. So that is very early stage coming up. And focused ultrasound. And by the way, the CAR construct, there have been some negative trials with the CAR construct also. So the other is focused ultrasound. There are so many clinical trials running focused ultrasound. I mean, in neurology world, it might be FDA approved for tremors or other things, but nothing approved yet for brain tumors. But focused ultrasound can be used in different combinations and is running as a clinical trial. So at UVA, I had at least 2 patients treated with TMZ and focused ultrasound. So that clinical trial is now published as very early. I think that was also a phase 2 trial, which was used to that focused ultrasound helps interrupt the blood-brain barrier and helps the TMZ penetration and all that. So the patients was getting focused ultrasound at the same time the patients were starting TMZ. So that was the trial, and the early results are coming that it's very well tolerated, safe, enhancing drug delivery that can be seen. So, but a lot of other combination clinical trials are going on with focused ultrasound. There is one that is running at UVA, and a couple of other centers is with 5-ALA and focused ultrasound. Then there are other trials where a combination with the chemotherapy for better drug delivery can be used. So, I mean, hoping to see use of that in future here. So that's exciting. So yeah, so ending my this speech with trials. So always consider a patient, of course. Send it to us. So we currently the gamma tau probably looks like is not, if I'm not wrong, open to enrollment, but we enroll a lot of patients there. So the ones which are open are the GBM trials. There are a lot of NRG Alliance trials open. So this would be upfront treatment of GBM. I have one. I have another one which was supposed to start end of October, but maybe soon would be a combination of anti-LAG3 and anti-PD1 for recurrent GBM. So that's a big deal to have any kind of recurrent GBM trial, especially with not much treatments change there. And then other trials, Dex trial is coming up, and then we have meningioma trials, the radiation meningioma trials, and of course the brain mets trials, which are all radiation trials, which we currently have open. So if you have any patients. So that is the end of the presentation today. Again, the CME code for all of you.
Thank you for your talk, Dr. Sarai. I was wondering, do you happen to know if those CAR T or synthetic versus, I think there's been some efforts, at least in treatment with types of cancer with allogeneic CAR T cells. Do you happen to know if
Yeah,
there's
I don't know offhand which were synthetic or not, but there were a couple of trials, but I have not seen any promising results for any of those. Yeah, CAR constructs.
another question too with the focus ultrasound and barrier penetrance, big trials for immunotherapy. You mentioned immunotherapy.
Yes, there is. So, I mean, we are interested actually in those trials, but yes, there are with pembrolizumab. And then with other chemo agents that had no good blood-brain penetration, so they are tried, which would have not been otherwise tried in these GBM patients here. So there are multiple trials, but we don't have any results yet. Yes, Dr. Nam.
One strategy I haven't heard about is taking advantage of the fact that both neurons and glial cells are pinocytotically active. And are there any strategies that you could envision where that would be a useful way to, some differential activity in the pinocytotic mechanism, or that the cells could pinocytose something that would give them indigestion?
It's a good question, not that I know of, but that would be maybe our basic scientist here can answer, but I have not known a trial or, any research regarding that. But I mean, maybe it's a good topic to study. Any questions online? I think I see something in the chat. Okay, got it. Okay. Thank you.